I had done a talk last year for the network with my colleague Kim Loring, who's a psychiatric nurse practitioner and director of behavioral health at CHP, and on more of the why and the benefits and the need for size inclusive care in healthcare. And I know that there was an appetite for sort of a deeper dive into more of the how of size inclusive approaches to care. And so I immediately knew that I wanted to invite Rebecca to speak with me. I learn more from her every time I see her. And I just knew that she would be such a valuable resource and have so much to share on this topic with me today. So without further ado, let's go to the next slide. Okay, here's what we are hoping to achieve with y'all today, learn a little bit more about. Again, just trying to dive deeper into these concepts and how it might look day to day. We can go to the next slide. So just wanted to do a little bit of a recap, especially in case you did not catch the sort of part one of this talk last year. Some things that we tried to establish in our presentation last year, really highlighting the impact of weight stigma on patients' health and where it shows up in healthcare systems, how just how impactful, how harmful it is. It permeates all aspects, right? Both, it internalized weight stigma, interpersonal weight stigma, and systemic weight stigma. So it's really at all levels of care and experiences for patients. And it has a whole host of health risks, right? Some are just highlighted in this graphic here, like increased risk of depression, anxiety, psychiatric disorders, suicidality, cardiovascular disease, overall mortality risk, right? These are really significant risks that are all associated with the experience of weight stigma. And so we are just trying to really highlight the impact. And as the size inclusive care coordinator at CHP, I have the privilege of hearing a lot of folks' stories and experiences. And the recurring theme is that, there's such relief when they find out about our initiative at CHP and a real sort of impact of like, I have been avoiding care for years, or I wouldn't have been able to show up today if I hadn't known that there was sort of this almost like protection of like they're less likely to experience weight stigma when they come see a size inclusive provider, right? And that's just the folks who know about the initiative at CHP or know about me and my work, and there are so many folks that are likely still not engaging in care, not showing up anywhere, right? And also experiencing the physical harms of weight stigma. So I could stay on this slide all day. This is a whole other presentation. So I encourage you to go back to part one, which I hope will be on the website too when that's up, and go to the next slide to kind of talk about the rest of the stuff we tried to cover in that presentation in a few minutes. Big ask, I know. But also we tried to highlight just how impactful health behaviors, supporting folks regardless of focusing on weight, right? We see numerous health benefits to physical activity regardless of where weight ends up. We also see health benefits to approaches to nutrition that are not focused on weight as the outcome, right? There's a lot of evidence to suggest that engaging in health behaviors regardless of where weight and size end up support our health immensely. So hopefully that will just whet your appetite to go back to part two if you weren't with us last year, and we'll move into what we're working on today. First, a definition. Okay. So again, this is the definition that we created last year. Again, just trying to set the stage of what we're talking about when we're talking about size inclusive care. And I'll let y'all read this on your own, but essentially the essence is really we all want the same things for our clients and our patients. We're just talking about different ways of sort of going about it, right? And many of you may already be sort of practicing from a size inclusive lens, either like explicitly, like you've heard about this approach and or health at every size, and you're already sort of on this train, or maybe without even knowing it, right? A lot of the concepts that we're talking about are really patient-centered, and really honing in on the goals and needs of the patient. We are also just trying to layer in a little bit around the understandings that we have of the impact of weight stigma, which your patients may not even know they're experiencing, right? A lot of this is unsaid and just so deeply embedded in our culture. So this is a way of sort of just getting your eyes and ears like perked up, or maybe just refreshing what you already know around this topic. Okay.
And I think I wanted to share too that when I originally came into this work many, many years ago, I mean, as I got into being a dietitian and a personal trainer, really from a weight-centric lens. And some of my initial experiences with the idea of size inclusive care, I think brought up different feelings for me, and made me feel a little bit uncomfortable in the work because I think for anyone else who might be out there, like we do want to do what we feel is best for our patients, and we are trying to support them in the best way that we know how. And when you're kind of trained in that more weight-centric lens, it really makes it feel like anything other than weight as the parameter, as the outcome of choice is really difficult. And we get scared of knowing, like, what are we doing? What do we need to evolve? What do we need to rethink a little bit more? And so I think it's natural that as we're kind of going through some of these slides, like if you're not already doing this work, you might have feelings and some uncertainty about what it means to actually do this. And I think as Annie so well pointed out, is that we have to remember where we are coming together on the same page and that we are trying to have good outcomes for our clients. We are trying to support them with finding health behaviors that really work for their whole life and their whole person. And it's when you start to kind of like dig below like what it means to focus on weight and how that deviates from health, where you start to have your eyes open a little bit. Um, and so like even like these are some of the misconceptions that I think people commonly have, or the resistance to doing size inclusive care, right? Believing that we're just going to throw quote unquote health behaviors out the window, when that's really not what we're saying. It's not about kind of eating whatever you want, but it is about making sure people are meeting their nutrient needs, and that we're not using a person's weight or size as a barometer of whether or not they're worthy of meeting those nutrient needs. Um, Other misconceptions that sometimes come up about are like that we're trying to say that health outcomes don't matter. Nope, that's not what we're doing. Like this is still about trying to help kind of people have good glycemic control, reducing cardiovascular risks, but it is about trying to move away from weight as the measure of whether or not health behaviors are effective. We're not asking people to be apathetic. We're not trying to enable, put that in quotes, um, problematic things within like behaviors, if you will. But we are trying to help people really pursue health behaviors that are in line with their own lived experience, right? Where trauma might be showing up and keeping people from doing things that are maybe in line with like their health risks, right? What is in line with their culture and what is in line with their care values, and exploring a little bit more.
Beautifully said.
Mhm.
Next slide. Okay, so this one, this graphic I found in preparing for this talk, and I just loved how beautifully I think it really lays out the impact of stigma in diabetes care, right? So I tried to highlight a little bit of what we covered last year around the impact of weight stigma. And I do really think, Rebecca and I talk about this all the time too, that it's just sort of so, if there's a Venn diagram around weight stigma and diabetes stigma, they are pretty overlapped. There's not a lot, sort of separating them, in the sense that a lot of the same sort of stigma stigmas that are focused around somebody's weight or size often carry through into diabetes stigma, especially for folks with type 2, and all these different ways, perceived stigma, the attributions that get applied, the practices, right? The actual experiences people have to like go through, right? And then how that actually impacts their health, like psychologically, behaviorally, medically, right? It shows up everywhere. And folks, especially, the clients that I work with in larger bodies, if they have a diabetes diagnosis at any point, I know it sort of multiplies, right? For them, that experience of that stigma, because they feel like they are already sort of failing in the cultural or aesthetic expectations of our world, and then also in the sort of health expectations of our world. And so they feel like they lose even more privilege, right? And have to experience a whole lot more stigma, which is really true. And so I love the mitigating strategies at the bottom also as a call to like where we can kind of try and counteract that or dislodge some of that shame that they're experiencing with both of these stigmatizing identities. We can go to the next slide.
So I promise we're going to get into applications. We wanted to make sure that we laid the foundation first. And we also wanted to clarify that while the bulk of this presentation is focusing on kind of general diabetes topics and primarily at a lot of like type 2 kind of interwoven, there's a lot of weight stigma in type 1 diabetes care as well. And we'll see it with clients kind of primed from the start, wherein they feel like they did something wrong when they're diagnosed and start to treat with insulin, and suddenly their body is gaining weight. Especially in our adolescent clients, wherein they feel like this was something wrong that happened because they're starting to care for their glucose. And they're left in this really difficult place of, am I managing my diabetes? Am I am I allowing the foods in my life that bring joy and bring experiences? Or am I kind of navigating other more problematic behaviors with insulin use and food choices? And leads clients to really almost choose experiences about appearance over their health, right? Of feeling like the appearance of health is more important than the actual health and the systems and functions within their body, which is ultimately what we're trying to focus on within size inclusive care. You'll see this with clients where there's this tendency to really clarify what type of diabetes they have, because one feels like a quote unquote failure, whereas another is like a genetic, is a an autoimmune condition, right? So people feel a need to like prove that this was imposed on them rather than something that was due to their quote unquote negligence, which is also not the case in type 2, but is the social narrative that people often have around it because of that association. Providers, and I often have well-meaning providers position like the danger of overcorrecting lows with like weight gain, like feeling like that is the only risk in terms of like the glucose management, really leaving clients really afraid of what they can do to care for themselves. So it gets people out of the space of curiosity and into more fear. We can go on to the next slide. So this is kind of when people are coming into the diabetes care experience, they can have their own expectations that often come back to weight, wherein, clients they are terrified of this diagnosis of diabetes and they're unsure what to do about it. They are so afraid about what this might mean for their future, maybe from past experiences that they've had with family members. And so they have a desire to try to fix what is going on really quickly, and that often means that they choose extreme and unsustainable behaviors because they want to get away from this fear as fast as possible. But that often leaves people in a place where it's unsustainable and not in a way that's actually in line with their overall life. Clients also want reassurance that their changes are quote unquote working, which makes weight-centric care so appealing, where if they have this relief that if they're seeing changes on the scale, it must mean that what they're doing is better for them overall. And while that might give them distance from the fear, they also really struggle to cope with like what happens when the reality sets in that like the weight loss may not be sustained, and we may not also be addressing the overall things in their life that are driving certain behaviors. Clients are also primed for more weight-centric expectations because of the deep shame and fear they have around feeling like they did something wrong to arrive at a diabetes diagnosis, and therein feel the need to prove their worthiness. And that desire to prove worthiness also creates some isolation, shame, and avoidance, both in the clinic and within their support systems. How many times clients will say that family members will say, well, it must be because, and they just feel such deep feelings about that and a need to prove their quality. Um, Also, there are a lot of like the care around diabetes initially is sometimes really extreme and oversimplified top-down recommendations that again set clients up for more of that weight-centric paradigm, and it leads to a sense of failure and avoidance when they really struggle to actually achieve it and apply it in their day-to-day life.
And I think it's also something that our sort of our current system of care really encourages. Like we're often really time limited. I mean, our patients are really time limited, right? And
Mhm.
so it's often like there's a huge immense pressure, I think, on us as providers to provide as much information as possible, or condense the information as much as possible so that they can just try and take that with them. But like Rebecca's saying, and I think we're trying to aim for in this talk, is that often is really unsustainable and leaves folks feeling really um, frustrated and shameful when they can't meet those targets.
Care avoidant.
Mhm.
Yeah. Mhm. Next
Shall we?
slide.
Next slide. So we are trying to sort of frame the more practical piece of this talk around some of the ADCES's self-care behaviors. These ones in the center are what we're aiming to tackle today. I know I'm studying for the CDCES right now, and I've been really encouraged by the real patient-centered focus of the ADA and the ADCES in their recommendations for CDCESs. And so I think what we're trying to accomplish here is even just more of an expansion on that movement towards patient-centered care from these guidelines. And we'll go to the next slide.
And I
Oh,
think while many of these guidelines on like as they stand really are about kind of like size inclusive care, our interpretation of them is really what matters. And so we're going to also point out like how we can shift interpretations from more of that weight centric lens into a more size inclusive lens.
said. So we have some recommendations around sort of like what we can be thinking about in our first or in the first few meetings with someone. Really trying to start very early on if they have been diagnosed with type 2 or even prediabetes to start like dislodging some of the shame associated with those diagnoses, right? Maybe that's acknowledging the complex etiology of the disease, and really trying to emphasize that there's a whole host of factors that coalesce into a diagnosis of diabetes and that it is not their fault, right? This real like person, individual shame that someone has. It's like, I brought this on myself, right? That doesn't help them in any way, shape, or form better care for themselves. And so also trying to get a sense of like, right, where are they? Are they in a place where they can be curious? Are they still reeling from their diagnosis? Are they so filled with shame or so focused on achieving these very specific, rigid goals that they don't feel like they have any flexibility to kind of explore? Or, maybe they're so heightened and afraid and so filled with fear that they can't really interact with the numbers, say, that they get sort of bombarded with like a CGM, if that's even something that's indicated for them. Rebecca, do you have any?
I think some of it is really assessing their sense of urgency around the situation and helping them understand that while there are lifestyle factors that they can utilize that are there, it doesn't need to be an overall overnight. in a sense, but we do need to kind of like do a little bit of an inventory about what are the opportunities for change and how do we start to kind of really build a foundation around some of those opportunities to create sustainable change. But too often clients are just so eager to just get rid of the diagnosis, and there are so many books out there that say that that is what can be done, that it's really tough for clients to kind of think that what does it mean to actually live with this and work with it in a meaningful way that incorporates my values and my experiences as well.
Here.
Mhm.
Next slide. So again, we're sort of framing it with the principle and taking what the principle sort of says from the ADCES. And there's a lot of really good recommendations, the tools that patients can use in trying to get a sense of how nutrition plays a role in glycemic control for them. But I think, again, it's really about interpretation here, right? I don't know if y'all have the same experience with your caseload, but oftentimes I find tracking food to be extremely problematic for folks. There's a that's where a lot of the rigidity or the obsessiveness can come in and a desire to control. But for some folks, it can be really helpful or an information gathering tool, right? Same with nutrition labels. And same with the eating pattern in this chart. I think there's a lot of really great, elements here, but even just sort of invitation to eat certain foods more often and limit certain foods can just engender that same binary that leaves folks feeling really stressed.
And
And
I'll offer too, Annie, that for some clients, even some of these recommendations of like reading a label, they can have such strong feelings of like, I need to avoid it due to like the I'm gonna use a big word, but like trauma around it in the sense of if they have an eating disorder history and how they have utilized labels or calorie or food tracking in the past. And so they can come into a session with avoidance if that's something that's recommended. And it's almost a self-preserving thing though, right? Where they don't want to go back to their eating disorder and they don't trust themselves to be able to interact with it in a really curious and compassionate way. And so you get clients on kind of two of the extremes where they are either using the information to be really rigid and really fearful, or they're really struggling to interact with it because they don't trust themselves to do it in a way that doesn't hurt them. And
yeah,
we want to come to the middle. Like that's the goal. Come to the middle.
right. There's even implicit messages. Like I just noticed there's no like just carbohydrate section on this chart.
Mhm.
There's like non-starchy vegetables and fruits, but like not bread recommended or listed anywhere rather, which I think, in the more sort of rigid interpretation, because again, our brains really like sort of black and white, that would mean never, right? It's like it's not even didn't even make the
Well,
list, maybe.
I don't even, well, it doesn't give you any opportunity for how.
Mm,
How do I include like foods that are culturally very important to me or socially or just emotionally very important to me? So giving tools and resources.
yeah.
Mhm.
Next
Next
slide.
slide. So these are some of the different interpretations people might have around some of these nutrition guidelines, depending if they're taking a weight-centric or a size-inclusive lens, right? So if we're looking at something like tracking our food, when it's done in that real kind of weight-centric lens, it's usually done in the spirit of kind of quote unquote controlling the food intake, right? Trying to adhere to like a certain number. I think tracking food can be done, and ideally it's done in the spirit of curiosity for people to really understand patterns and opportunities and reflect back on like how it feels within their system, right? So for my clients who are ready to do kind of tracking in their work, we might do it on a really short-term basis, not to try to control what they're doing, but to kind of notice energy patterns, to notice glucose patterns, to be able to reflect back on like what was a high and a low, and not to use the high or a low as judgment or a shame, but as a learning opportunity for, okay, well, if I had like rice with this particular experience and my glucose went high, I wonder what I could do to it to make it help it so I don't have to get rid of my rice, but what are my options to actually make this work for me? So getting more into like we can notice patterns with tracking, but we're trying not to use it in a punitive measure. Um, Label reading, when it's done in a weight-centric lens, is often about trying to minimize calories or to decide whether or not you can have a food. When we're thinking about it from a more size-inclusive lens, we're really leading labels to understand what the food does and does not kind of promise or offer, in the sense of like, no food is going to give us everything that we need. Every food is going to give us a different combination of nutrients. And so our job at the end of the day is try to put together the combination that really works for us and our glucose management. So, if something has like more simple sugar, less fiber, less protein, that doesn't mean we can't have it, but it's also useful information to say, all right, well, if I have this, it's going to do X to my blood glucose. Is there a different portion? How might a different portion feel for me? Or how might it feel to add this to a more well-rounded meal rather than having it on its own? Weight-centric interpretations are often that lower calorie is always better. But when we're thinking about it from a more size inclusive lens, it's about like we have to remember that calories are an approximation of the nutrients within the food. So if we're cutting the calories, we are cutting carbs, proteins, and fats, which are limiting the substrates in our body. And we want to work with people to understand the value of all of the nutrients and all of the functions, especially as it pertains to like the different times of the day. Like I have clients who are athletes and do have diabetes, and it's them understanding that like every substrate has its own job as an athlete. And so timing matters. And then it's not about just like getting rid of it or trying to do the most activity with the least nutrients because we're missing out on other things then. Trying to, weight-centric lenses might have like good and bad foods, like really making it into a binary. But in this size inclusive space, we're really trying to help people understand that all foods have their place and value. But we get to kind of decide how we put them together in a way that matters for our values. Another big one is that weight-centric care will often kind of provide this like implicit or even explicit message that only certain bodies can have treats or pleasure in food. And that is no, right? But it's like, we really want people to understand that we can balance glucose management and joy that is accessible for all. It is not a privilege only reserved for certain bodies.
I think the morality piece runs so deep, right? I mean, so many times I'll be in a session and clients will share like, oh, but like food that supports my health couldn't possibly taste good, right?
Mhm.
It really has to be this kind of like slog or suffering, and
You have
that
to
because
earn it.
that's
Mhm.
what we've been taught, right? It permeate weight, the sort of the weight centric lens permeates, and the morality permeates our culture from the very beginning, so it's often really hard to even consider or fathom another way, right? This is definitely more of a sort of experiential thing for folks to step into rather than leaning on like numbers or charts to really determine whether they're doing good or bad. Like that, getting comfortable with complexity, I think, is one of the cruxes here.
Hey. Next slide. So when we're with our patients and thinking about how to really apply some of this, the big shift is I'm a huge fan of thinking about food is not simple. I wish it were. That would be really cool. I think we were taught that as dietitians, that if you just tell people what to eat, that's all you have to do. Just educate them and that'll all work really, really well. But it's very similar to this analogy with the tree, wherein the education is really what's on the surface. But so much of what's happening on the surface is informed by our thoughts and our beliefs, and even deeper still by our relationships. And so not understanding what is going on for like a whole system of a person can have really negative impacts and harmful impacts for a person. We can be sharing something that we feel is super neutral and not problematic at all, like a recommendation of think of clients who were told like don't eat bananas, have berries instead. But if you don't understand the whole person and like what it means to have one versus the other, and like it can create some really tricky things down the road wherein it's what is the financial cost of that? What is the relationship to that? What are the beliefs that a person has attached to one thing or another, or the ability to make those choices? And so when we're working with folks, it's thinking about, are there nutrients that we can add to help them balance glucose rather than always emphasizing that they need to take away, especially if we're doing that for certain bodies and not others, right? That is something to kind of challenge within ourselves. it's important to understand their willingness to do something and their fears to have different experiences, the fears that can come up when they are asked to do one thing versus another. You know, sometimes we as providers can do a recall and see something that's low hanging fruit of, oh, we could just not do the soda. That would be easy to kind of help you manage your glucose. But that might feel like the most difficult thing for that particular person to do. And they might find that other things are actually more tangible and might help them feel more success in that process. A huge underpin to a lot of this with working with clients is like having consistent intake. So eating regularly with a balance of nutrients to support appetite hormones so that it stays regulated and doesn't get into the dysregulated space that leads them to feel really in conflict with both their body and their choices. Yeah.
Yeah, I think when we're operating from like a more, historically like weight-centric or didactic perspective, there's also, for patients, this real desire to just sort of stuff down any experience from their body, right? Like we're really living like from the neck up, and we're just following the sort of rules or the plan that has been set by whatever diet or maybe the clinician that we met with, and just trying so hard to ignore our experience and get the sort of good feelings from following the plan. But that really doesn't add in those experiences that wise biological hunger, right? Same with the sort of piece of folks thinking that there's sort of good foods, bad foods, or, eating as little as possible is the best they can do for themselves or their diabetes. That doesn't really acknowledge all the important roles, like Rebecca was saying, for all these different elements, right? Like, would we just replace the oil in our car and never, ever put gas in it? Like, we would never go anywhere. We might have a nice, like, shiny engine if I knew how cars worked, but like, that's about it. Like, there wouldn't be anywhere that we could go to experience. We would just be stuck in our heads or in our, I guess, engines. I don't know. That one went a little way, but anyway, next slide. So, yeah,
Yeah,
go
go
ahead.
ahead, Annie.
I'll just start with the thought about for providers, like really trying to leave assumptions at the door, like your soda example, Rebecca. This is just I had a client who was feeling so much shame around her soda consumption, to the point where I assumed that she was talking about regular soda, but she was in fact talking about diet soda, which changed the nutritional picture in my mind completely, right? But because of the way she was explaining it to me, I made an assumption about what she was talking about. And so constantly being as curious as possible, basically always assume we don't have the right idea in our minds, and we need to check in and ask to make sure we're on the same page as our patients. Same with our assumptions around body size, right? Believe your patients when they are telling you that they are, eating X, moving Y. They are not, trying to sort of give you any other picture than what actually is there 9 times out of 10, right? And so just starting with believing them, or getting curious about what you're seeing versus and the discrepancy, and not moving into assumptions around what they must be doing because of what they look like or how they present, etc.
Yeah, I think and even within that, it's getting curious about like how they might feel sharing details about what they're eating and the shame that's coming into session for them. And so it is a bit of, and this is a privilege in many ways of kind of being a dietitian and having more time in session, especially now being more like outpatient. Like I have more time and more access with people to really develop a relationship where they know that they can share and be honest about what's working and what's not working, rather than just trying to like make me happy or do the things they think they need to do according to the internet. This is a lot of it is asking questions, like we're saying, and recognizing that eating is a 5-part process. And when I've done like nutrition assessment education sessions for medical students, the first question I'll get is like, how do I do this with less time? I'm like, I don't know if you can without making assumptions. Assumptions are the only way to do a shortcut, because to truly understand what is influencing a person's food, we have to look at all of the different factors. Um, eating is a 5-part process. You have to decide what to eat, get the food, make the food, eat the food, and then like clean up and recover. And what is sticky for any person is going to be a little bit different. Like where for some people deciding is really not the issue, but everything else is. And for others, it's they just can't get the food. They don't have the transportation, but they don't mind cooking it. They don't mind deciding. And so it's figuring out where within this like 5-part process do I actually need to be supporting this person to help them kind of continue to work on their journey. Really, really important to always be screening for relationship to food and body, regardless of body size. Eating disorders are very prevalent in type 1 and type 2. When we think about eating disorders, we often really are focusing on type 1. It's really common in type 2, but unfortunately, it's often the disordered behaviors are really encouraged. And the shame around the diabetes is also felt to be like just a normal part of it. And I don't think it is. And so really understanding what is their relationship to food, body, and movement.
I also am really buoyed in studying for the CDCES exam to see a lot of call outs for screening for disordered eating, right? So continuing to try to assess where folks are with that is really, really important. Next slide.
I love exercise.
And
Go
I
ahead,
think this
Danny.
principle has a lot of great ideas, right? I
Mhm.
mean, I love this be creative box that they have a ton of suggestions, and many of them could be, accessible for folks. But, it's again more about the sort of how of these recommendations, and how we go about it. So I'll let you take it from here, Rebecca.
Oh, yeah. Let's go to the next slide, please. Thank you. So I won't read each of these to you individually, but I think the greatest thing that I see folks running into is that they pursue a movement program. They have this weight-centric lens, and so they do as much as they can with the least nutrients possible. They don't see the scale move and they quit. That is like the summary of it. I'm like, well, we kind of missed the point of what movement is really all about and how movement actually helps support the different functions internally. And that's what really matters in our overall health outcomes, regardless of what it does to the scale. But too often I see clients who are engaging in movement patterns and they're doing it to just expend calories and forgetting about this like adaptation piece. Um, and we need nutrition timed appropriately to actually drive a lot of these adaptations, right? To support our cardiovascular fitness, to support our endurance, to build our bone, to build and maintain our lean muscle. And if we're not giving our body the nutrients that we need, we end up actually losing and missing out on a lot of those benefits. Because a lot of like the sports nutrition concepts are not contingent upon body size. It's really contingent upon sport and physical activity and the adaptations we're trying to pursue. Clients will get really fixated on needing to do a certain type of movement because it expends more energy, or that it's only worth doing the movement if they hit a certain distance, duration, or rate of perceived exertion. But they're missing out on like the parts of movement that are really about all movement will either directly or indirectly support some aspect of physical or mental health. Like none of it is empty, just like no food is empty. It's all kind of doing something. We just need the blend that really works for the outcomes that we are looking for. And our bodies are going to adapt to the stressors that we put it under. So it doesn't matter if you had 20 minutes planned and you only did 10. It doesn't know that. It knows that you gave it 10 and that's what it's going to adapt to. So it's all going to contribute towards something. But we don't need to be compulsive with it either. We can ebb and flow the movement just like we would if we were training for an event where you don't just do the same thing every single day compulsively, right? I know we want our clients to be consistent, but I want them to also be responding to the stressors in their life and what their body is communicating. Because if they are exhausted, pushing the movement is not going to help them see more adaptation and benefit. It might actually be the opposite. So there's nuance in when do I push it? When do I dial it back? So like I really try to help clients think more like an athlete of doing things with their body, really helping it see it as an ally, see it as something that they can work with and develop, rather than always trying to do things to their body and forcing it to change.
Yeah, I just want to bring back your tree analogy here because I was thinking about the like the more we target the thoughts and beliefs, the more flexible we can be there with
Mhm.
ourselves, the more flexible the actions and the behaviors can be to whatever is coming our way.
Something is always possible, right? It's thinking about a lot of our health behaviors almost like a dial, if you will, rather than an on or an off switch, where no matter we can dial up the intensity or dial down depending upon like what else is going on in our life.
Yes, normalizing the adaptation to our daily lives is
Yeah.
so critical. Next slide. Right. Okay. So you can't really say movement without talking about the impact of weight stigma in physical activity. It's so prevalent everywhere. I'm gonna shout out Aubrey Gordon's book, What We Don't Talk About When We Talk About Fat, just a little bit more on that experience, lived experience of fat people, especially around movement or maintenance phase. But, again, this is just a critical piece, especially when you're working with clients in larger bodies, right? They feel very much like they are not welcome and also uncomfortable being there themselves. A lot of my clients talk about that sort of hyper vigilance of like, if they do enter a gym, right? With just even, that's just more the traditional exercise route. If they do enter a gym, like, is somebody going to say something to me? Even a congratulations can feel like really, stigmatizing, right? The person means well, but it's really sort of saying again, like you need to be here or you should be here or good for you, you're working on your health. This whole, I think that one of the biggest challenges for fat people is that, and I use fat in a neutral way, is that they are very visible, right? And so that can draw both positive and negative attention, both which actually can be very unhelpful for them figuring out what kinds of movement are really enjoyable for them, feeling both unwelcome or maybe overemphasized in a setting. Um, just being one. I really like this graphic from another qualitative study that just interviewed folks that highlights all the different ways that it can show up.
Annie, I'm curious, how would you respond to someone who is struggling with some of the fears of like what might happen if they engage, like socially, if they engage in movement? Because I think sometimes well-intending providers want to like talk people out of those experiences and say like that doesn't happen or that's not real or that won't happen to you.
I think actually naming that it is very possible and it might very well happen is extremely validating for folks. Same with, potential experiences of weight-centric care, especially like believe clients when they share their stories of weight stigmatizing experiences with providers, right? Because there is a real sort of, again, even internalized feeling for them that they may have sort of almost made it up, right? They're not real, but back to your question, Rebecca, it's more about maybe we can like sort of like role play a potential interaction and how would that feel, right? And depending on how that feels for them, right? Are there other ways that they can sort of protect their space and still pursue the kind of movement activity they want to pursue and work up to that, like almost like an exposure therapy experience of like, where is comfortable for you? And where might, when you're feeling ready and comfortable, be the next place that we sort of dip a toe into the less comfortable and more, potentially stigmatizing experiences.
And yeah, I think that in part comes back to the fact that all types of movement are going to have benefit. Clients can sometimes believe that they must be at the gym and sweating. Just sounds a whole sweat is not about fitness. It's about cooling. But the belief that fitness can only be done in a certain place. And so I must be in that place in order to get what I need. And so it's getting creative with clients about like where are the spaces where it would feel a little bit better for you to engage in movement in a way that makes sense for you.
Yeah, absolutely. Next slide.
Ooh, I love movement. For a lot of our clients, I think it's depending on their background or their experience with movement, and their relationship to what's going on with their glucose, there is often a desire to go out pretty hard. Clients want to do the recommendations that they see online, they want to do what they did in the past, and they really forget that when it comes to movement, there's a foundation that we need to make sure is firmly in place before we build upon it. And that foundation is not super sexy, super fun, right? When we're thinking about like working on mobility, addressing pain, like it doesn't get you the glory. You don't see the outcomes with your glucose right away, but it really is about kind of scaffolding the movement to be able to do the more fun things. And so a lot giving clients even permission that like it's okay if we don't start with walking as an example, especially if you're struggling with like pain in your ankles and plantar fasciitis, like let's think about other forms of movement that might actually maybe we get to walking. Maybe that's something that's in the cards for you. Really thinking about what can we do to address some of those things with like mobility training, huge physical therapy proponent. If we can to really work on like looking at soft tissue ergonomics is another really big factor for folks that I want people to look at to if someone is sitting all day because of their job or whatever showing up in their day-to-day life, sitting all day, all the time kind of puts the structures in a certain place. And then if we're asking you to kind of stand up and ambulate, the body might not be prepared to do that, resulting in a lot of like back pain and knee pain and ankle pain that puts a lot of clients in this really frustrating cycle of engaging in a movement pattern, getting really injured, feeling in a lot of pain, engaging in it, and they just kind of keep in this like doing too much too soon. So really, want to get people to start from where they are, not from where they were in the past, and really thinking about how do we build the movement program from that and build that structure. Also really important to work with clients to think about how can we adapt clothing or equipment to support your body. That can be a really challenging thing for people where, getting the right sports bra, getting the right shoes that have adequate support, making sure they've got clothing that they feel comfortable moving in and they had, financially can afford as well. Addressing concerns around like sweating and chafing, which can really get in the way of being able to do movement. Anything to add, Annie?
Yeah, I mean, it's just more around the strategies of these pieces. Like some people, no matter how many times you may sort of gently and open-endedly be like, are there any other concerns you have around this activity that we're talking about? Like anything that might, be a barrier to you or something that's worrying you about this? They might not even think to share it, or they might not feel comfortable sort of volunteering it. So you can also share, like, a lot of folks talk about their anxieties around, or their, how uncomfortable they feel when they're sweating, or, the chafing that can sometimes happen with movement, right? So really just kind of trying to like bring these things up, name them, and really create the most neutral, inclusive, welcoming environment for clients to share those anxieties, and be a champion for resources for them, right? Crowdsource your own resources. Like if they need, plus size or extended size activewear, right? Maybe you have a list you can share with them, or something to that effect, right? Or a community, there's a Boston area's Fatties Facebook group that is extremely helpful for resources of any and all kinds, since we're in Massachusetts. But there's many more resources where those came from too. You can share with them. Next slide.
So for providers, remembering that helping clients know the personal benefits of movement for them, what they are looking to get out of it, how, right? And so it's more about them and how it improves how they feel in their day-to-day life, whether that is, I feel more energized, I have more tolerance for really frustrating things in my life, or even if it's just about like, I know that I'm doing what is right for me and my diabetes. Really trying to get out of all or nothing thinking that movement doesn't have to be done in one way at one duration. You don't have to. I bring up the sweating thing because I had a client who was told by a provider that they need to sweat more in order to get their glucose down. And it's like that they need to get their heart rate up. They need to work on their cardiovascular fitness, but that's not going to be demonstrated by how much sweat that they produce. Focusing on values and quality of life, that's huge, right? As well as the integration of their culture, what feels appropriate, what feels safe for them, and really working to understand that. Movement, especially in public spaces, is not the same for all of us. And so what we feel really safe doing is not going to be the same for some of our clients and what they're experiencing. Really, if you can, help assess clients for where they are and connect them with professionals who can help them build upon that space in a way that is right for them. And remembering this movement pyramid, where we're kind of, working on building that foundation from the bottom up. So lots of health benefits of movement that you can see on the right that are not contingent upon how much a body size changes.
Next slide. Okay, medications. Boy, are we trying to accomplish a lot today. So, just again, a little bit of a highlight of what the principal says right now, but I think, especially in the age of GLP-1s, which we will get into a little bit, it's really, we're talking about taking it to the sort of the next place of like, what are their thoughts and beliefs about taking medication? What kind of maybe shame or things are they holding out on? Actually, maybe we can go to the next slide while I'm talking about this. Right. Because typically in weight-centric care, we're choosing medications, often with an eye on how that impacts weight, rather than, in diabetes care, like how it impacts their cardiovascular disease risk and glycemic control. Weight can often sort of take the front seat in the decision making sometimes. And the belief that, certain medications are better for certain bodies, right? There's a sort of hyper focus on defining care based on body size or targeting weight specifically rather than these other, I think what we're trying to point out here, maybe more important elements in medication targets, right? Like glycemic control and cardiovascular disease risk. And same, clients actually really come to us with this too. So providers and clients alike can have this belief that they really need to exhaust all the lifestyle attempts before introducing medication. And so it can come from either side or either direction. But also trying to be, mindful of maybe what the risks are for medication avoidance and being able to sort of dive into those beliefs, those values, those fears, right? And continue to sort of foster that flexibility around these things, right? Even though, like some of these medications might be taken for life, right? But can we have the flexibility to experiment, to find what actually is supportive in the short term rather than feeling sort of hemmed in or defined by that potential permanence, right, of some of these drugs. Next slide. Okay, so this is just a little sort of way to maybe explore this with patients, right? Trying to include your patient in the decision making if they wish to be a part of the decision making, right? This can also vary by culture. Some folks really want to be told, or want the provider to tell them what they need, what medications they need to take. And others would really benefit from that conversation and exploration around their values and their hopes and their fears around taking different medications. And some of that even, by culture, you can assess their preferences or maybe what fits in with their lives, right? Like not everyone can, just to name insulin as an example, can be taking insulin up to 4 times a day, right? That might not fit in with their life. What other medications might be more accessible or more appropriate? You can discuss that and really invite your patient to be a co-decision maker in this, or the decision maker, and you're just sort of providing the background, the information, the informed consent, the risks and the benefits, right? While also exploring maybe those underlying fears, because we do know that taking medication is so also stigmatized, right? For a lot of patients, it can feel like confirmation of their fears, like they're sick, and what that identity for them.
I did a bad job because I need medication and or more medication.
So true.
Yeah. Mm-hmm.
Shall we move to the
next slide?
So
wouldn't be a talk if we didn't talk about GLPs. I
right.
think GLPs play a role, I think, in size inclusive care. I really do. I because it depends on our relationship to the medication, how we're framing them, and how the client is framing whether or not the medication works. if you will. So when we're thinking about like GLP-1 medications, too often like people are thinking that appetite or eating is the problem to be solved, but I think we can't lose sight of the reality that like we need to eat. Our body still needs nutrition, consistent nutrition in order for functions to occur. So it's really making sure clients are still consistently eating even if they are taking a GLP medication, because so much of the benefit isn't just in the weight loss, it is in the improved glycemic control and the reduced frequency with which people need to take a lot of these medications. So really trying to help clients shift about like how are we evaluating whether or not this medication works, moving away from weight being the outcome as opposed to how it's actually maybe improving my relationship with food, eating consistently, my ability to make choices, any dysregulation that I'm feeling around food.
And there's so many themes that I'm seeing with these medications, right? I think both patients and providers alike are drawn to it because it reduces appetite, but that is also sort of leaning into that weight-centric approach, which is that eating less is always good, which we know, especially as nutrition professionals, is not the case, right? There are a lot of things that we can potentially miss out on, from a nutrient perspective that are really important. And it's not just protein, I
Mhm.
promise.
Mhm.
And same with, sort of the energy with which like both patients and providers are coming to these drugs with the expectations, right? I think tempering expectations around weight loss expectations is also really important because again, this is another place where patients can feel like failures if they don't, elicit a certain amount of weight loss. And they might also be engaging in some risky behaviors. Again, if you're going into it hoping that it's going to reduce your appetite, you might also be sort of intentionally leaning into that side effect quite significantly, which might have some other consequences to it as well. But like Rebecca, you said, it's an incredible tool for glycemic control. It can give a lot of folks their quality of life back, but we want to be really intentional in how we're, like how and when we're prescribing it. And, are we pushing for the max dose, right? Versus like titrating based on like, well, maybe we're in a great place, like with our glycemic control, and maybe we want to hold off on stepping up until we actually, want to elicit more of that benefit for, improving your A1C, right? Why are we, pushing so hard to get to the max dose? It's often for this desire for weight loss, which might not actually be the most beneficial approach for long-term glycemic control.
And I think I have, so many clients who are in bigger bodies and they have eating, like they are struggling with an active eating disorder. They often do not believe that they are because of the size of their body, and then go to their provider hoping for support around like that they have fat around their liver, that there's presence of insulin resistance, and they're offered a GLP, and they often are not sharing the fact of how rigid their diet is, how much they're not eating, how much they're struggling with binging before engaging with this medication. And so I'm grateful when they are willing to have that conversation with me and then be more honest with their provider. Because I think part of we cannot just trust that our clients will know and offer that they are struggling with eating disorders, that they occur in all body sizes. And so we also need to be actively screening because unfortunately, when we're giving a GLP in the context of a restrictive eating disorder, like it just takes away the evidence of like, I need to eat because there's no hunger anymore. And so suddenly the clients are just reinforced that like, I just don't need to eat. And so it really increases the mental health impacts, remembering that eating disorders are mental health conditions that have physical health impacts. And so it's this interplay as providers that we need to make sure we are asking all the similar questions we would of all body sizes.
Next slide.
Next slide.
Right. So again, more just a reiteration, right? Trying to be aware of maybe what beliefs around body size or the again, how we've all been sort of taught in weight-centric healthcare settings and in school, like to focus on weight, like consider, focusing on these other metrics of health. And also exploring as always, the patient's desires and roots. But I think also we should have put in like giant letters, like screen for eating disorder,
Yeah.
how much of their desire, right, is also a reflection of their eating disorder thoughts and or behaviors. I think, again, a lot of folks struggling with maybe a less restrictive eating disorder are hoping that this medication might elicit the restrictive behavior that they haven't been able to sort of elicit in themselves on their own.
Yeah. And sometimes clients will say, well, it's in the past. That was my eating disorder was put in, is over. And we really do need to really understand how much it's kind of still hanging around. Because sometimes they say it's over because they're in a different body, but a lot of the thoughts, fears, and rigidities are still quite there.
Yeah. Excellent. Right. Okay. So we'll just dive into healthy coping in the essence of time. These were just some of the examples that they gave, and I think, maybe you get the gist right now that it's not quite as simple as just sort of hopping from one coping tool to another. So we'll go to the next slide.
And coping isn't about the change in the body. And clients will sometimes like engage with things like mindfulness because it might help them eat less and change the size of their body, but that's not what mindfulness is, right? Mindfulness is quite literally not judging what we're doing, but it's paying attention to the present moment without judgment. And so like if we're shifting from a weight-centric to a size-inclusive lens, it's helping folks remember it's not necessarily about like eating less. It's about being more present and increasing our distress tolerance. Um, Comes up often that there's this belief that emotional eating is always quote unquote wrong and needs to be controlled. I would argue it really needs to be understood. There is a role that it's playing in a person's life, and the more we try to just control it, the more we miss out on the role that it's playing and how we can actually help the person heal and diversify their options. Emotional eating is, we're human. And so we do engage with food when we're happy, when we're sad, but we don't want it to be the only tool people are using to cope and work through distressing things. Huge one is, it will commonly come up that folks express distress around their body, and well-meaning providers will say, well, we'll just fix the body then. Annie, you want to give a size inclusive approach on that?
Right. So, I mean, again, I think this is often like a destination that folks think that they're going to reach when they're following a weight-centric approach in their own care, right? Well, if I just get to X size or X weight, like my life will be different. I will feel better about all these things. And what, even folks that sort of reach that theoretical destination come to find is that it's actually much more a reflection of these other thoughts, feelings, beliefs that they're having about themselves that are sort of being reflected back in their perceptions of their body and their distress around their body, right? Because the body is a representation of themselves. And so of course, it's sort of like a prime target for sort of like coalescing all of that distress in one place. And of course, it could be very neatly, sort of reflected in the larger culture of like, oh yes, this is everything that's wrong with me is just have to do with my appearance, my size. And then we get into actual size oppression, right? And it really does impact their daily lives in any number of ways, but often that reflection is not actually about the body until we're experiencing oppression, and then it's a nice little distressing mix. Next
Next
slide.
slide. I love so it's really helpful for clients to understand the distinction between what is coping and what is controlling, or AKA avoidance. I think the stress and bucket is a really wonderful analogy to use with clients to really understand the distinction, wherein like some of the behaviors that we might turn to, they do alleviate some of the pressure of what's flowing into our bucket, but they're also kind of adding like things to the system at the same time, right? So things like compulsive exercise, alcohol and drugs, self-harm, risk-taking. And I think it's even like obsessions like healthy eating can kind of, if it goes too far, quote unquote, I'm going to put that in quotes, where it becomes more about I'm engaging with food in a way because I'm terrified, it's actually adding more stress into the system than it is actually helping alleviate it with kind of healthy coping. So the coping are the things that actually help remove stress from the system. And any of these behaviors are going to look different person to person, wherein like it really depends on their relationship to the behavior. It's not necessarily the behavior itself. So anything could technically become an unhealthy coping behavior when it's really rooted in avoidance. And so it's helping when we're working with clients to understand what is their relationship to the behavior and is it actually adding stress or alleviating it.
I think that's so important, especially for these behaviors that are really culturally encouraged and recommended, right? Especially for folks in larger bodies. Deb Burgard has a saying that we diagnose in thin folks what we recommend for fat folks, right? And so oftentimes they can just be sort of, doing everything right. But actually, those are just going right back into their stress bucket, just focusing on this graphic and actually creating more distress or more harm in the long term. The ways that we try to fix, it tamps down the distress just while it's in that little green tube, and then it comes right back into our bucket.
Next slide. I swear we're almost done. So, when working with clients, it's a lot of just understanding the role a behavior has within their life rather than trying to kind of encourage it or demonize it and distinguishing between like what is coping versus what is controlling. A lot of the different strategies that people use, like in different styles of therapy and mindfulness, are ultimately about kind of expanding that window of tolerance, right? Which is our capacity to kind of take on and recover from stressors. And that window of tolerance can really get impacted by so many different factors. There's a lot of great resources out there that aren't necessarily direct like mental health counseling. I'm a huge fan of mental health counseling. It's not accessible for everyone. I wish it was. But it isn't what everyone needs. It isn't accessible for everyone, and there can have a lot of feelings that keep people from actually pursuing it. Some other resources like MBSR, which is mindfulness-based stress reduction, mindfulness-based cognitive therapy and resilience. Those are kind of structured mindfulness programs that are about kind of increasing a person's capacity that are offered through like some of the different institutions in the area, like Cambridge Health Alliance, and I think UMass as well has a program. Which are just great for just giving people more tools and resilience that you don't have to do as a provider. Peer support is also another phenomenal resource that I think is growing more and more, but even offering groups is another really great space. When we used to do groups at the hospital for clients navigating diabetes, none of them wanted to be there. I'm going to start there. No one electively signed up. A lot of their providers kind of told them that they had to go, but then many, I would say all of the clients who attended were so grateful to be there because it was the first time they had talked with anyone about having diabetes, including their family, because they felt such shame around trying to navigate it. And so creating those peer support systems is so helpful for folks.
Community is so, so powerful for, stigmatized identities, whether it be diabetes or larger bodies or both, and many more. Yeah.
Next
Next.
slide. This isn't easy. There are a lot of challenges to this work. We both come from community care and we understand how much time is limited and resources are limited. And it would be so wonderful if we could just hand this to our clients as and have the time to be able to work through it with them. And some of the severity that clients are navigating, we may not have the time that we really need to build these skills and work with these beliefs and these philosophies. Still think it's a valuable approach to care, but also want to recognize that sometimes time is of the essence. May not also align with all kind of client or cultural expectations, and it's not our job to necessarily impose these values or practices on others, but really rather offer it as an opportunity for care. I certainly practiced from this lens when I was in community care. And so clients would get referred to me for weight loss. And I wasn't going to turn them away, but really, offered like more questions about how do you feel about your body? How do you engage with movement in a way that's about adaptation? So I wasn't telling them they couldn't have what they wanted, but also really did a lot of work to offer them more tools and resources that were inconsistent with kind of the health outcomes that they were looking for that may not give that. It may not be so much about like seeing the change on the scale. And they were grateful for that, even if it wasn't what they were looking for initially.
Next slide.
Anything to add, Annie?
No, I think resources is again, like this is just a starting point here. Like we are both, I think, a wealth of resources, and I really encourage you to shoot me an email if you're ever looking for a resource for anyone or anything. And I will do my best to scrounge some or many up for you. The resources we have here, we tried to focus on diabetes, but again, just the tip of the iceberg. And hope that they're a nice jumping off point for you in this work. Next slide. Thank you so much for
Thank you.
having us, and we are welcoming your questions.